Hello, everyone, and welcome to this Hoosier Extracorporeal Science Conference and NRP series brought to you by Heartbeat Perfusion Solutions. If you're not familiar, Heartbeat Perfusion Solutions is a national provider of specialized perfusion and extracorporeal membrane oxygenation services, also known as ECMO. They offer critical support for cardiac surgeries and patients who require advanced life support, working alongside hospitals and surgical teams to ensure optimal patient outcomes. Their services include expert staffing, equipment, and management for both short and long-term perfusion and ECMO needs. I'll be your moderator today. My name is Sam LaLiberty, and I am joined by Ignazio Candello. Thank you so much for being here.
Thank you so much. My pleasure.
Ignazio is the editor-in-chief of Perfusion Times and the chief perfusionist at Anthea Hospital based in Italy. He earned his first PhD in 2019 for research on artificial intelligence in extracorporeal technology, and a second in 2024 for his work on optimizing extracorporeal techniques in cardiac surgery. He's currently co-authored over 128 publications. Thank you so much for joining us today.
Thank you so much. My pleasure.
So Ignazio has prepared a presentation for you today, and then we'll save time at the end for us to do a bit of a fireside chat where I'll be asking him some of the most common questions that we receive in this space. But really, we have 4 key objectives for you today. We want to explore how NRP impacts the selection of donors, particularly with respect to age and health, and how this differs from more traditional criteria. We'll also explore the economic and operational considerations for integrating NRP into transplant centers, as well as the current state of research that is aimed at optimizing NRP techniques, along with the role of NRP in maintaining and assessing organ viability, how variables such as duration and the donor health will influence the outcomes post-transplant. So we encourage you to reach out to our speaker today or even Heartbeat Perfusion Solutions if you have any follow-up questions on today's material. So at this point, Ignazio, I'm going to stop my screen share and pass things over to you so that you can get started with your presentation, and then I'll come back here at the end.
Can you see the presentation?
That looks perfect. Thank you.
Okay, I start. Hello, everyone. It's a great pleasure for me to introduce this presentation about normothermic regional perfusion and the impact of technologies and evidence-based protocol. I am very happy today share this presentation because normothermic regional perfusion have international breadth in the community and increase the availability and the quality of organ donation. I am the editor-in-chief of Perfusion Times. I want to thank for all followers. We had the achievement of 1,000 followers. We have we are very proud about this achievement, about the newsletter production for important series about the treatment of normothermic regional perfusion. My current workplace, I am a cardiovascular perfusionist. I work in Anthea Hospital of Gruppo Villa Maria in the south of Italy, in Bari. It's an adult cardiac surgery center, and we expand our horizon about in the future in normothermic regional perfusion. So I have a disclosure for this presentation, and I want to introduce the normothermic regional perfusion. Normothermic regional perfusion is a technique used to restore blood circulation and oxygenation in the organs after cardiac death in donors. It enables the preservation of organs at normal body temperature of 37 degrees and improving the quality of viability for transplantation. I write recently a paper that treat this aspect because I think that it is really important the diffusion of technique for increase the donation availability in the world. This is a graph about the donation after circulatory death versus the donation after brain death in the various countries of the world, in particular for the Europe, for the Australia and the USA, about the 2022. I think that this data increase in the 2024, in particular in the next 2025, and we observe that the places and the country with an increase of the donation after circulatory death are the Spain, the USA, the United Kingdom, and the Netherlands. The difference between this country is about the protocol, in particular for the diffusion of this approach. And we have two typology of the classification of that. The first is the neurological cases for the determination that, and the second is the cardiorespiratory determination of that. These two classification involve the donation after brain death and the donation after circulatory death. When occur the donation of brain death? When we have absence of the neurological reflex, the patients remains on ventilator through organ recovery. Once the brain death is declared, and the organ procurement organization in the hospital start with the procurement of organ. The donation after circulatory death is with two-way, with normothermic regional perfusion and with direct procurement. The cases of death is the absence of blood pressure, the pulse or cardiac sound, no spontaneous respiration. And this is many classification for the circulatory death depends on the country. There is a higher availability and difference for each country. This is the classification from Maastricht for the donation after circulatory death. We have four categories. The first is an uncontrolled death on arrival, in particular in emergency department. The uncontrolled with unsuccessful resuscitation in emergency department, and the controlled is a cardiac arrest follows planned withdrawal of life-sustaining treatment in intensive care unit, and the either cardiac arrest in patients with brain death in intensive care unit. This is the classification that use the United Kingdom for best practice and guidance in donation after circulatory death. And I believe that today I share this protocol because it is one of the country that have a good rate of donation after circulatory death. The donation after circulatory death is different from the donation after brain death because in the brain death we have a reversible coma, apnea, absence of reflex. And in the 2022, the traditional pathway of these donors is 97%. The donation after circulatory death is no brain death, but injury with no maintainable neurological recovery and potential to significantly expand the pool of donor organs. We have two techniques, the direct procurement perfusion and the normothermic regional perfusion. Today, we explain these two typology in terms of cost management, in terms of quality, in terms of timing and organization and management. In this approach, we observe the difference between the direct procurement and perfusion versus normothermic regional perfusion. We observe that in direct procurement and perfusion, we observe that there is um, a high duration of ischemia time for the organs. When we start with a normothermic regional perfusion, we observe that we have an increase of perfusion time without ischemia time. In both approach, the data is an oxygenation, hypoxic oxygenation less than 70%, hypotension with less than 50 millimeters of systolic blood pressure. In direct procurement and perfusion, in this context, in this protocol, use machine perfusion ex vivo. And in the second approach, using the cardiopulmonary bypass or extracorporeal membrane oxygenation before the agonal phases. Nevertheless, we have another protocol that is the association of machine perfusion as cardiopulmonary bypass or ECMO without the cold storage and the use of ex vivo machine perfusion. This approach increases the perfusion time of organs and expand the quality of the organs before the donation. I want to share in this context because I think is the most recent the upgrade is in 29 August of 2024, the protocol of United Kingdom for normothermic regional perfusion in controlled donation after circulatory determination of death. I think that is really impressive because this approach have a good organization and management of the members of the team and describe the technique for use and prevent ethical problem during the use of normothermic regional perfusion. In particular, this approach treats the abdominal normothermic regional perfusion that involve the restoring of perfusion in the liver, in the kidney, in the pancreas. In particular, use extracorporeal membrane oxygenation with oxygenated blood at 37 degrees for a periods of typically of 2 hours. The recovery from warm ischemia increase and supply the ATP reserves and assess the organ function and the quality, unless ST retrieval. Normothermic regional perfusion shown to increase the utilization of all abdominal organs and significantly improve the outcome of liver and the kidney without adverse effect on the pancreas. For the liver, it is associated with better transplant survival and a very low incidence of cholangiopathy when compared to DCD conventional donors. For the kidney, it is associated with a better renal function at 12 months. This protocol details the technical aspect and the procedures and is written with regards of legislation that observe the Academy of Royal Medical Colleges. In this context, a composition of the team is most important because it's a team specialized in the clinical practice of normothermic regional perfusion. It is important to have a theater practitioner scrubbing for organ retrieval, organ preservation practitioner, advanced perfusion and organ preservation specialists, in particular with advanced technique and experience, 2 surgeons accredited as competent to perform abdominal normothermic regional perfusion. Thoracic and cardiac surgeon may attend for the retrieval of thoracic organs. Separate protocol exists for these organs. and the adaptation of this protocol in these circumstances are discussed in other documents. So, the mobilization of this team, because the donation after circulatory death with the mobilization team arriving because 1-2 hours before the withdrawal time, and is combined with a cardiothoracic team. The scheduled arrival should be 2 hours before, and it should be noted that abdominal team will need at least 2 additional vascular clamp to when a combined retrieval is planned with the cardiothoracic team. These clamps are applied to large vessels to permit heart and the lung retrieval will remain in place on the cardiac team have gone and must carry out by the abdominal normothermic regional perfusion team. The setup for blood units is most important and depends on the technique that was used to prelevation of organ. For example, for standard abdominal normothermic regional perfusion, 4 units of red blood cell, and for abdominal normothermic regional perfusion with the heart and the lungs was used in the experience 8 units of red blood cell, and only thoraco-abdominal normothermic regional perfusion 6 units in the protocol for ordering the blood. This is the approach. Once the donor hospital, the abdominal retrieval team should inform local theater staff. They should discuss the relevant protocols and identify who can perform blood gas analysis, that is a point of care device. Similarly, someone should be identified to run samples to biochemistry laboratory if a point of care device is not available. The point of care is the blood gas test, and for liver and the pancreas use the specific laboratory test to understand the efficacy of normothermic regional perfusion. This is the normal practice at the donor hospital regarding the time systolic blood pressure falls under 50 millimeters of mercurius, and the time of circulatory arrest are recording to the current practice. In addition, the time of normothermic regional perfusion is commenced and stopped. We also need to be recorded. The acceptable duration for retrieving of a specific organ should be discussed with the implanting team, but these are likely to be longer than considered when YDCD donors in warm normothermic regional perfusion is performed. So, the pre-retrieval preparation involved several steps. The first is the scrub practitioner will set up the operating environment in a similar fashion to the current practice for donation brain death. These include the setting the diathermy machine, 260 milliliter catheter, the aortic and inferior vena cava cannulas, the connection between the proposed cannula. Once the potential donor systolic pressure has fallen below 50, after circulatory arrest, the sterile part of the normothermic regional perfusion circuit should be handed to the scrub practitioner. The arterial and venous cannula should be opened at this stage, and opening them earlier may result in wastage do not die. Approximately was prepared in this context if there is involved the thoracic organ, the organ care system heart machine. The setup depends on the machine used. In particular, for the extracorporeal membrane oxygenation, there are many typology of circuit and oxygenator. In particular, there are many techniques to administer the anticoagulation. In particular, the heparin in the donor before circulatory arrest, not in premorbtem intervention, but in Maastricht for donors. Heparin can be given. A suggested dose if is 300 units, around to 50,000 units for 80 kilos person, given just prior the treatment. For the preparation of cold perfusion fluids depends on the protocol of the centers. In this context, two 1 liter bags of cold University Wisconsin solution. So the standard prime for extracorporeal membrane oxygenation is a bicarbonate earthman solution, heparin, methylprednisone, antibiotics, and this is the prime solution in the United Kingdom national protocol. For reduce the hemodilution is important standardize the priming in relation to the typology of patients. For example, for the patients of over 50 kilos, a larger prime volume will reduce the risk of empty reservoir, and reduce the length of the circuit is a good compromise to reduce the hemodilution and the administration of red blood cell units. The cannulation typically for normothermic regional perfusion is approximately the 19 French cannula, Medtronic Biomedicus, or other alternative in relation to the anatomy of the vessels, typology of the patients. And the femoral vein approximately is 25 French cannula. If there is a difficulty arising during the femoral vein or arterial cannulation, the surgeon need to be prepared to switch to abdominal cannulation. Typically, the extra time taken to compensate to be able to restore the circulation to the abdominal organs before cold storage. This is the difference, is a flow chart between direct procurement and perfusion and normothermic regional perfusion. I think that there is a little bit difference because we observe that between the two procedures, the use of extracorporeal membrane oxygenation is really low cost than the use of organ care system about the circuit and the procedure. This is a technique about normothermic regional perfusion available in every cardiac surgery center because it is a extracorporeal membrane oxygenation machine. You can use a polymethylpentane or polypropylene oxygenator because it is a low time, is approximately 2 hours of perfusion, and decrease the cost and availability in the center. The other aspect today in relation to the use of normothermic regional perfusion are about ethical aspects, because this is a approach for abdominal normothermic regional perfusion. You observe that the patients was cannulated in the femoral vein and in arterial the arterial cannula was positioned, arterial femoral cannula, and a clamp was positioned in abdominal aorta. The problem is this: there are many school about the preservation of the brain during the normothermic regional perfusion, because it's possible that we have a collateral circle that support the cerebral circulation. And this increase the ability that increase the brain activity, no, during the normothermic regional perfusion. This technique suggests that not clamp the carotid and subclavian vessels, but are open during the normothermic regional perfusion, and put the arterial cannula in the ascending aorta to drain the blood flow if there is a blood flow from the brain. This decreases the incidence of perfusion of the brain during normothermic regional perfusion. The other aspect is about the management of thorac-abdominal normothermic regional perfusion. This is the approach is similar to normothermic abdominal regional perfusion without clamp in abdominal aorta. We start with the perfusion and the heart start with the rhythm, we occluding the epiaortic vessels. And when the heart start the rhythm and we observe a good contractility, the patient was intubated and the organ was retrieval and start with gold solution and was transported for the donation. This is the how we set the institution of normothermic regional perfusion. We connected the tubing line to the cannula without air, okay, and we set the temperature of 37 degree. Approximately, we start with the oxygenation with 21% of gas blender with 2 liter of gas flow. Today we have a technology that we put the value of PR, CO2, or oxygen partial pressure. This is our old setting. Because high oxygenation concentration may generate reactive oxygen space and can exacerbate the reperfusion injury to the organs. The preferred time for conditioning the organ after ischemia for normothermic regional perfusion is approximately 2 hours. This is the setting about the hemodynamic and the biochemical goals. We observed that approximately empirically for this approach used a pump flow of 2-3 liters minutes, a temperature of 35.5 or 37.5 degree. The air maintain a venous saturation of 60-80% and arterial is 7.35, 7.45, and hematocrits more than 20%. The gas flow maintain the arterial PCO2 of 4.5 to 6.0 kilopascal. That approximately is 40 millimeters of mercury. For the biochemical evaluation, serial sample gases every 30 and 60 minutes and ALT and AST are taken to assess the organs. In particular, during the institution and the management, a perfusionist can add blood or colloid or fluid solution to improve and support the flow. Not is involved the use of vasoconstrictor use is not involved. To assess the parameters of the liver, use transaminase to assess prevent the liver damage marker. And the other benchmark of quality of perfusion is the lactate as a function marker. The lactate should follow over the course of 2 hours, the perfusionist and the team monitoring the trend, but may not reach normal values due to the venous return from upper body and non-perfused limb. Clamping the intrathoracic inferior vena cava may be associated with a greater fall in lactate measured in the circuits. The other technique is biopsy before and after of normothermic regional perfusion, both, and kidney biopsy after normothermic regional perfusion are supported for service evaluation if it is appropriate. For the pancreas was monitored the amylase in the patients if indicate that there is pancreatitis, and the visual appearance is more useful. For the kidney, the urine output falls off, may stop completely during normothermic regional perfusion. There is a not useful biochemical market. For post-normothermic regional perfusion, the appropriate paperwork should be filled and a copy sent with each organ. Failure to establish normothermic regional perfusion. If not established, initial cold perfusion should follow the standard DCD protocol. So I want to share in this context for the first time. This is an article that I write that was accepted in Journal of Extracorporeal Technologies from AMSECT about the potential benefits of monitoring oxygen delivery in relation to oxygen extraction ratio and production of carbon dioxide during normothermic regional perfusion in donation after circulatory death donors. This is an interesting article because it explores the application of new nadir to improve the quality and monitoring recording during the normothermic regional perfusion. Because today the world really changed. The standard monitoring is the systemic mean arterial pressure, the cardiac index, the blood flow, the urine output, and the blood gas analysis value. Nevertheless, we observe in the previous protocol that the protocol today have many limitations, no? Because in particular, talk about the point of care for evaluation of the blood samples. But I think that today is most important have an online monitoring of this parameter. Because traditional blood gas monitoring during cardiopulmonary bypass or ECMO procedure require an invasive arterial and venous blood sampling, which carry the risk of infection and microemboli production and hemolysis. The benefits of online blood gas monitoring, in particular for normothermic regional perfusion, expand new horizon. In particular, is a real-time monitoring of the patients, and you assessed in the real time the blood flow, the parameter, the oxygenation, in a not reactive way, but in a proactive solution. The continuous monitoring of blood gas levels, any imbalance and abnormality can be detected in the real time about hematocrits, PaO2, PaCO2, arterial venous saturation, oxygen delivery, VO2, and pressure parameter. Is an immediate interaction and intervention in the early stage. In this context, in this paper, we try to transfer the know-how of cardiopulmonary bypass, in particular for the prevention of acute kidney injuries. Many studies assess that more than 280 of milliliter minus square meter of oxygen delivery prevent the risk of acute kidney injuries in particular for normothermic regional perfusion, found in the future a target parameter to prevent the damage of kidney or increase the quality of kidney is a good point to start from normothermic regional perfusion. The other aspect is about one paper that I write in 2020 about the association between oxygen delivery and the cardiac index for hyperlactatemia during cardiopulmonary bypass. I found that the benchmark in the normothermic regional perfusion or thoracal or abdominal, the benchmark is the lactate trend. And the use of oxygen delivery in relation to mixed venous saturation or extraction of oxygen ratio is a good solution to prevent the lactate production and reduce and conditioning the lactate during the normothermic regional perfusion. This vision I believe that expand the quality of the monitoring of normothermic regional perfusion. For example, the oxygen extraction ratio is a formula about the relationship between the consumption and the delivery of oxygen. The consumption of oxygen is the index volume of oxygen consumed by the tissue per minute, indexed to body surface area. The oxygen delivery is the amount of oxygen delivered per minute indexed to body surface area. These parameters have many formula, but today is possible during the cardiopulmonary bypass or extracorporeal membrane oxygenation recording this parameter. And recording this parameter is important to assess the quality of our work in relation to the outcome of organ preservation. I think that expand this approach in the future will be found an adhere to protect the kidney, the liver, the pancreas during the normothermic regional perfusion. The potential benefit of monitoring oxygen delivery in relation to oxygen extraction ratio and VUSIO2 during normothermic regional perfusion in DCD donors are the optimized organ preservation, ensuring oxygen delivery matched to metabolic demands of the organs, reduce the risk of ischemic injury, and improve the quality of the organs being preserved for transplantation. The other aspect is the early detection of metabolic imbalance. Monitoring VUSIO2 in relation to oxygen delivery provides a early warning system for metabolic imbalance, such as hyperlactatemia, which indicate an insufficient oxygen delivery. The other aspect is the personalized perfusion strategy, the ability to monitor to adjust oxygen delivery in relation to oxygen extraction ratio and VUSIO2. And this approach can lead to more consistent and reliable outcome in organ preservation and transplantation. The reduced risk of post-transplant complication, no? Because maintaining an optimal balance between oxygen delivery and the metabolic demand. The incidence of transplant complications such as acute kidney injuries, delayed graft function can be reduced, leading to better long-term outcome for transplant recipient. And the other aspect that I not write in this paper that I explore in the future is the collection of data for production, the evidence about the use of this parameter during normothermic regional perfusion. Thank you so much for your attention, and I concluded my presentation.
Thank you so much. That was a lot of really amazing information. We're so grateful to have you here today. Do you need a sip of water? I know that's sometimes a lot before
Yeah, yeah,
get
yeah.
into a bunch of questions for you.
Thank you so much. I
Thank
am
you.
very happy to share this different point of view about the normothermic regional perfusion. Thank you.
Absolutely. And so I have a number of questions prepared that we are often asked about NRP. And one is always around how the selection of donor criteria differs when you compare NRP to more traditional operations and procedures. So, how is it different?
So thank you for this question. Is a good point to start. Normothermic regional perfusion involved the restoration of blood and flow than the other donation without normothermic regional perfusion. This approach decrease the ischemia time and improve the perfusion and reduce the ischemic damage, because when the organs have no flow time, increase the ischemia, and ischemia increase the apoptosis and impact the function of the organs. The normothermic regional perfusion is a available approach in all center with a relatively low cost approach and improve the availability and the quality of organs because reduce the ischemic time and increase the restore of oxygenation in the organs after the declaration of death. Okay.
Hmm. Okay, thank you. And now, when we're thinking about actually adopting NRP in transplant centers, what are some of the economic implications that people would be factoring in?
Yeah, is another good point of reflection because the problem is not the circuit or the oxygenator, but is the organization because around the normothermic regional perfusion we have many allied professional, the surgeon, the structure, and you have an increase of equipment organization cost. For example, require specialized equipment, no? For example, extracorporeal membrane oxygenation, machine monitoring system.
Mhm.
The reduction in organ wastage, improving the availability of the organs for improve, for example, the donation is a good point of start. For example, if you increase the cost of materials, you balance with availability of the organs. I believe that this technique not really improve the cost, but is an investment to improve the quality of life of the patients. This is my perspective.
No, we appreciate your perspective. Thank you for sharing that with us. When we think about the current research that's being done, what is happening right now? What's being conducted in an effort to really optimize NRP techniques?
For optimize this approach is important the training between the professional involved in this process is important the monitoring system and the device use because today the problem about the use of normothermic regional perfusion are concerned about the ethical aspects because the patients when died you give a new metabolism to the organs. These aspects is for assess these important aspects is important to use all technologies to reduce the problem about the ethical aspects. So I think that the training, the standardized, the procedure, the ethical and the legal consideration, and the coordination with donor network and the literature, I think that is the key to spread this technique. Thank you.
So it looks like there's a lot of progress being made in the area, and that it's very new, and really just getting started in this space. So that's exciting to hear. When we think about the key components of the NRP technique, just to really break it down for everyone who might not fully be using this or familiar, what are the key components? And then talk about some of the potential complications that are associated with NRP and that could arise.
Of the potential complication associated about the normothermic regional perfusion are different. For example, when we use an extracorporeal circuit, the problem is about the coagulation, the thrombosis, and embolization. The other problem, the technical complication, are about the embolization of the hair during the use of extracorporeal circuits, the difficult monitoring and management of the venous return. The other aspects are about the inflammatory response, because the restoring the blood flow after ischemia may increase the reperfusion injury, and this increase the inflammation, and this is another problem. For summarize, is thrombosis risk, embolization, difficulties in monitoring, and the other problem are the aspect about the ethical and the legal challenge,
Hmm.
because many country have different opinion, no, about the use of normothermic regional perfusion. Many countries sustain the direct procurement of the organ with the machine in outside the body, and I think that the ethical aspect is another potential complication aspect associated with normothermic regional perfusion. Thank you.
You mentioned the monitoring techniques, which can cause some challenges. So, what are the monitoring techniques that are being used in NRP when we're thinking about assessing the viability of an organ?
So today, for increase the spread of this technique, the protocol propose a standard approach. For example, the blood gas analysis, the monitoring of lactate levels, the hemodynamic monitoring, the visual organ inspection, the temperature monitoring. But I believe now there are many systems and many techniques that improve the monitoring. For example, the NIRS, the spectrophotometry, the monitoring of the brain, or the continuous monitoring of blood gas analysis in the circuit without the samples. So it's a really interesting aspect. I believe that in the future we observe a new technology to improve the patient's outcome. Yeah.
Okay, thank you. I have just a couple more questions for you. One that we often get asked about is around the duration of NRP and how that can actually impact the organ function post-transplant. So after the procedure is done. What can you share about that?
But this depends about the protocol of the center. But I think that is most important monitoring the trend of the lactate. Because if you have a good perfusion with a reduction of a warm ischemia time, approximately 60, 90 minutes, I think as optimal to restore the organs. But this depends on the biomarkers and the lactate trend during the start of normothermic regional perfusion. This aspect of optimal duration of perfusion and the warm ischemia time impact the quality of organ, and I think that is most important control these two typology, warm ischemia and the duration of perfusion. Thank you.
Thank you. You've been so generous with your time. I have one more final question, which is around donor age and the health status of the donor. How much of a role does this play in affecting the outcomes of NRP? What do we know?
So it's a really important question because the patients that underwent normothermic regional perfusion have many criteria. For example, the older donors tended to have high risk of organ deterioration, after transplant. For example, the younger donors are resilient, are better, respond better to normothermic regional perfusion. The other aspects are in relation to the health status. Is important that the patients not have hypertension, ischemic injuries, problem about the kidney. The other aspects is the comorbidity influence the quality of organs. Uh, the selection of the donors is important. We use, yes, the normothermic regional perfusion to reduce the ischemic time, but it is important the selection of donors. Yeah.
Okay. Well, thank you so much. I know I've learned a lot and our audience will have as well. So we encourage you to reach out to Ignacio if you have any questions on this. I hope that's okay that I've shared that. And then if you aren't familiar with Heartbeat Perfusion Solutions, please visit their website and you can learn more about the services that they provide. This is our second webinar as part of this science conference and this virtual session that we're offering. So we have more in the works. We will be promoting these on social media as well as to our email list. So definitely look out for those. And thank you so much, everybody. That's all we have planned for today. Bye.